Right. Good evening. So thanks for coming to the indirect course for the Viva. So first of all, good evening. Good evening. So first of all, I would like to introduce myself. So hopefully most of the students might know me. So anyhow, I just want to introduce myself. So I'm Dr. Rajivan. Currently, I'm working as consultant obstetrician and gynecology at DGH Mullatiu. Actually, I do some practice and surgeries in Kalabovil as well. Yeah, Vanakam. Okay, right, fine. So I would like to thank to my students to work with me to achieve 80% pass rate. So hopefully we will reach the target, right? So first of all, I need to tell something about the the MCQ exam which held recently. So as we know, Obzangaini passed rate for last years, right? So it's around 30 to 35%. So we work together to reach to 80%. So what I felt about this paper this time, actually the paper is almost same as previous paper. Actually, the paper is a bit tricky, but most of the students, so almost all the students, the comment is the paper is easy. We could manage. The reason is I'm really happy because uh, people and our students understood the paper this time, right? Yeah, Charita, I'm right? Yes. So, good evening, Malisha. She's on the screen. So, so this time only students understood the paper. So, how to understand the paper, understand the question. So the simple thing is the background knowledge. So these are the things always I'm telling, background knowledge, right? So you need to know the background knowledge with the pathophysiological explanation. So this time you might experience, so how will be the exam, right? So what they're asking, so the previous exam pattern has been changed now. So the risk factors for preterm labor, risk factor for postpartum hemorrhage. So the direct question like scholarship students, it's changed now. Now they're asking about the pathophysiology, the explanation. So until you understand the subject, you can't do that. That is the first thing. Second thing you need to know is the rational thinking. These are the two important things, right? So the background knowledge and the rational thinking. So there is no fixed answers like the other subject. So if you study medicine, pediatric, surgery. So if it is a myocardial infarction, so always, if it is a chest pain, you don't need to worry. Give 300 milligram aspirin, clopidogrel, atorvastatin. So whoever it is, doesn't matter. But obgyn it's not like that. So there are options. There are options. All the options could be possible, but you need to select the correct option depend on the background knowledge. So rational thinking. So as an obstetrician, as an obstetric house officer, as an obstetric SHO, you have to be a rational person, right? So you have to be a rational person. So that is the very important part in obstetrics. So this time, most of the students understood that, right? So that is the reason now I could see more than 600 students here, right? Because people understand what is the real exam, what you want to know. And more than that, right? This is not only for the exam purpose. This is your career, right? So you are going to practice in the patient until you stop your practice. Even after retirement, you are going to practice. So what you are going to learn today, it's going to stay with you until you stop your practice. So this is not for the exam purpose. So don't do like how many class he's doing, how many class he's doing, who is a very cheap price person. So you are you going to be a cheap doctor? No, you are going to be the best doctor, isn't it? So always you have to think whether you are getting, whether you are having that knowledge for which you are paying, right? Okay, right. Now, anyhow, again, I'm also very excited to see your results. So hopefully we can reach 80 percentage. So most of the students uh, uh, this time got more than 20 out of 25 in SBA. So I'm really happy because we are going to have a good house of visitors. Now, so what is the difference between the Viva? So we have achieved a lot in theory. So now most of my students are having good knowledge. Now is it enough to practice to the patient? Right? So now you have completed one part. Now you are going to the another part. So actually the theory and the Viva, it's not same. It's almost a different thing, right? So your application of the knowledge and everything is different, right? So if you are a person can memorize, if you are a person can study well, if you are a person can read a lot, of course you can pass. But whether you are having knowledge or not, it will not determine whether you are going to be a good clinician, whether you are going to be a good doctor, whether you can pass the exam, right? Because completely we are going to apply your knowledge to the patient. So some of medical students who are working today with me, oh, they are doing the appointment with me. So today also I asked so many questions, they couldn't answer anything. Am I right? Yes, they couldn't answer anything, right? The reason is they don't know how to apply. Sorry. So what is the difference between the theory and the Viva? That is the first thing you need to know, right? So theory, you should have a deep knowledge, right? You should have a deep knowledge. So depth, very depth. So they're asking about the pathophysiological explanation and thing. But in Viva, it's not like that. You need to have a broad knowledge, right? So you can't be a straightforward thinking person. So you should think in a lateral way, right? As a patient, right? So I want to tell these things. Um, I'm doing, this is my fourth year of ERPM classes. So far my pass rate for the ERPM is almost more than 90 percentage in Viva than the MCQ. Almost always 90 percentage. So to achieve that 90 percentage pass rate, so I'm having a different kind of techniques to teach the students. So our way of teaching is totally different, right? So I have a own style to prepare the students. So I will not change that, because this time also you are going to pay. So my duty, I'm taking the responsibility to make you to pass the exam, right? So the students who are, of course, the junior students, it's a good opportunity to study, because if you exposed, if you know how to take the history, how to approach the patients, when you go back or whenever you get the chance to go to the hospital, at least you can apply your knowledge and you can get practice. And of course, as our common rule, you will get free access in future. So then even if you join, so this is a good opportunity to you to improve your knowledge, right? And second thing, for the exam batch students, this is not the theory, because theory, you read something, right? You read something and you are going to do with the paper. You are not going to deal with any human being. And second thing, in the paper they are giving the extract information. So 29-year-old primary mother with complication of diabetes or gestational diabetes presented to you with the abdominal pain and blood stain vaginal discharge at 38 weeks. So now you have given with all the information. You don't need to gather anything from the patient. So you know the history. Then among the history, or with the history among the answer, you need to find the answer. But in Viva, it's not like that. They are not going to give the scenario. You are going to deal with the uneducated patient. Sometimes they might be good educated, they might not be educated. This patient might be a cooperative patient, talkative patient. So because you know, right? So especially how is your boyfriend, how is your girlfriend, different people are suffering, no, right? So So yeah, of course. So then you are going to deal with different mentality people. But ultimate target is within that 7 minutes. You can't say this patient, bloody patient is talking a lot. How can I take the history within 7 minutes? Yeah, it's not applicable. Where the patient is talking, some patients are not talking at all. Doctor, Amma, why did you come? Patient is saying nothing. But you can't say patient is telling not telling anything what to do. Whether patient is talking, whether patient is talking too much, whatever. Some patient might be very angry, right? So whoever or whatever the patient, ultimately you need to gather information, right? And you have to present. So at the end of history taking, what you want to do is you want to identify the major problem. You want to identify the risk factors which she has, because you may have to do the risk factor modification. You want to identify the complications, which what are the complications he is having, because not only treating the diabetes, you may have to treat the polyhydramnios. Or if it is a chronic diabetes, you may have to treat the renal failure part or retinopathy. So you need to identify the complication, and you need to treat the complication as well, right? So you have to identify the problem, you have to identify the risk factor, you have to identify the complication, and ultimately you need to discuss with the professional. So when you come to the course, I will teach you how to take the history. Today I'm going to tell what are the important things you need to know, why you want to study this, right? And I will show you how difficult to take history. It's not an easy task, right? Because different people have different level of frequency. So as a doctor, what you want to do, you want to mold yourself to according to the patient, right? So if the patient is uh, studied up to A level, then you can talk up to that level. If a patient is a doctor, you can talk like that. If a patient is uneducated, then you have to go to their level and talk to them. Got it? So this is the main task. So you need to identify the patient's condition with their level. Second thing, you have to have a good rapport. How to develop a rapport with the patient, because especially not only the other subject also, especially in uh, obs and gynae, we are going to deal with a lot of sensitive issues. Maybe their sexual problem, maybe the extramarital relationship, or maybe something which even they can't tell to the husband. Isn't it lesson there? But they are going to tell to you. So I told you earlier. So when they are telling something, doctor, I have less of libido, or maybe I have less libido. That time your facial expression. So then you can right. So then you can't show your expression. So your facial expression, right? So your way of talking, the rapport within a minute or within a second, that patient should believe, okay, I can trust him, I can tell my problem to him, so I'll get some kind of relief from this problem. Got it? So ultimately what I'm trying to say is history taking is an art, right? It's not a subject. It's not, you can't learn from the classes or books, because the books will not help you to how to attend or how to uh, apply your knowledge or your skill to the patient. So that is in practice. So until you get practice, you will not develop that. Got it? So you have to develop it. And this is you can't become master on this in overnight, right? So if you want to cook very nice, so then initially you are cooking, usually people can't eat, right? So then you can't tell me. I have seen so many girls are telling, so after marriage I can cook very well. Do you think you can cook after the marriage immediately? No. So then what will happen? The problem will start with your husband. So what you have to do is you have to get practice before you get married. So initially you might forget to put the salt, right? Even after 5 years of marriage, people are struggling. Oh, maybe yes, yeah, yeah. Here, some people are with me. Yeah, they also telling the things are correct. Okay, so yeah, of course. So you have to do mistakes to learn, right? So you might think, okay, I will present very nicely in the exam. So it's not the case. Yeah. So what I'm trying to say is, so during this class, what you have to do is you have to practice, you have to present the history, right? Then only I can correct you. So these are the things you are doing mistakes, you need to correct this, right? So I will correct you how to present. So it's an art. So our class is going to be like a rehearsal. So the exam preparation, right? So this is how I used to do. So uh, why even though there are so many doctors, even though there are so many teachers, but few are good. Why? So everybody might have good knowledge, but the teachers you are telling good is he know how to reproduce his knowledge to the students. Am I right? Right? In a way they can understand. So in the exam, Viva exam, what you are going to do is you are going to reproduce your knowledge to the examiner. That's it. So if you don't know how to reproduce in a way to the examiner he can understand, even though you know a lot of stuff, you will fail. So you have to get practice how to reproduce your knowledge in the exam. That is the Viva, right? So no worry. So the students who are coming to my class, I will make you to present very nicely at the end of the course, right? You will be masters in history presentation. This will help you to present other subject as well, medicine, pediatric, and surgery, because the format is same. There is no history taking differences in obs and gynae and the other subject, but the obs and gynae history taking is bit difficult. The reason why I am telling it's difficult is, say I think I have told you earlier also, if it is a medicine, right? So if it is a chest pain, you have some differential diagnosis. If it is a joint pain, then differential diagnoses are different, like rheumatoid arthritis or something like that. But in obstetrics, almost most of the case, even 90% of the gynae cases are present with vaginal bleeding. Pregnancy, vaginal bleeding. Antepartum hemorrhage, vaginal bleeding. Uh, uh, Endometrial CA, vaginal bleeding. Cervical CA, vaginal bleeding. Fibroid, vaginal bleeding. Adenomyosis, vaginal bleeding. Now, only you have one symptom, vaginal bleeding. From that one symptom, you are going to identify the extract diagnosis from pregnancy to malignancy. So you need to think in a rational way. Otherwise, you can't. If a girl presented with heavy menstrual bleeding at 14 years, then it can't be malignancy. Why? Because you are analyzing the patient, the patient that is 14 years, heavy bleeding, regular bleeding. So it can't be due to malignancy. Malignancy changes need some time. It will be in the later part of the life. And second thing, from the day of menarche, she is having bleeding. So her bleeding is bit extensive. So she might have problem with the clotting. So then first of your differential diagnosis could be uh, due to clotting dysfunction, maybe hemophilia or maybe ITP, whatever. So this is how we are going to think in a rational way. So my course is going to be like this. So the first 14 classes, I'm going to teach you like how to take the history. If it is a diabetic patient, what are the questions you are going to ask? If it is a hypertensive patient, what are the questions you are going to ask? If it is um, heavy menstrual bleeding patient, fibroid, then what are the questions you are going to ask? If it is a dysfunctional uterine bleeding, what are the questions you are going to ask? So for the gynae and obstetrics, almost 25 to 26 cases, the common cases which they can ask in the exam, I will discuss. After that, then the second component will be case presentation, right? That is how I used to do. What is that case presentation? Especially the students who are waiting for the exam, right? Each and everyone need to present the history to me, right? So earlier what I did is I used to I'm the only person always taking the students to the hospital, right? So I never charge a single rupees for the hospital visit. That is my policy. This time also I would like to bring you to the hospital, but we all know, due to this corona restriction, even pregnant mothers will not allow others to come near to them. That is the real thing, right? If your wife or your sister is pregnant, will you allow 10, 12 people come together closer to them? Obviously, no. So until the corona restriction lift, hospital visit, I can't 100% say, but if the corona restrictions are lifted, then definitely I will bring you to the hospital, especially around the Colombo, especially Colombo or somewhere. But you will not pay. But even though we are not we can't go to the hospital maybe in early part or mid part of February, you are not going to miss anything in the hospital touch. So I'm not going to tell like uh, routine things like others. Obviously I can't give the wrong or false assurance. I will do because everybody knows now you can't cross the uh, 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 districts. But of course once they lift, definitely I'll bring you to the hospital. And my students, those who are going to the exam, at least once they have to do the exam in front of me. I will correct them individual basis. That is my routine practice. So when compared to other subject, obstetric and gynecology, you don't need to worry much about the examination things, because entire obstetric case, if you know how to do the obstetric examination, that's enough. Entire case, it might be hypertension, diabetes, no worries. If you know how to do the obstetric examination, that's enough for your entire obstetric case. For the gynae case, if you know how to do the abdominal examination, how to do the UV prolapse examination and speculum examination, speculum and VE, that's enough for your gynae cases. So if it is a surgery or medicine or pediatric, then you need to do the long case, short case, different techniques. But here it's not like that. We have a limited techniques, right? So this time hopefully they will not let you to, even in the exam they will not let you to be with the patient for a long time. So but they will assess you whether you are identifying the main problem, whether you are presenting properly, whether you are a safe house officer. So that is the thing we need to learn this time. So how to approach the patient, how to ask the question, right? How to identify the problem, and how you are going to be safe house officer, how you are going to be safe medical officer. Because if I am the examiner, what I am going to think is, if I pass this person, whether I can do class in the evening. Because if that person don't know how to manage the pph while I am doing the class, if there is a pph in the ward, definitely that patient will die. So that is the examiners, all the examiners expectation. Because they are not they are always not in the hospital. They are the visiting obstetrician and gynecologist. So if they need only, they will come. So then who is going to be the person, the primary managing person is the house officer. So house officer should know the important thing, right? So the examiner's expectation is whether this person is safe or not, nothing else. So you need to know what you must know. Even though you are having good knowledge, right? If you don't know certain points, they will fail you, because they will be categorize you as a dangerous house officer. You can't be a safe person. So the entire aim of my course is to prepare you to be a safe person. So that will help you for your career, that will help you for your exams. And I'm not going to force you to present the history. I will give the opportunity to everyone. So earlier we don't have much students, so you have good opportunity to, even some students present more than 10 histories. But this time I don't think. But whoever would like to present the history, you can present in front of others. I will correct it. So I will tell you why I want to do that. So it's not mandatory thing. I'm not going to force anyone to present the history. If you like, yes, you can present. If not, you can sit behind the camera. I don't mind, right? The reason is, if you get a chance to present, right, you are going to get the chance to get correct your history by me, right? So if I correct your history right now, you will not do the same mistake in the exam. You will pass the exam. But if you are not get corrected by me, then you are going to do the mistake at the exam and you are going to fail it. So again, you lose your age, and as well as the ovarian follicles, right? So don't lose your ovarian follicles, don't lose your dowry, don't use your time. So this time you have to pass. So I'm planning to do like that. So not only the common history presentation, also I will do the small group discussion as well. Now we can do through the Zoom case discussion. So I'll do it like a small group discussion. So then maybe 10-20 people can present the history, then I will correct it. So anyhow, all the students who are going to sit the exam, at least they have to present one history to me, either individual or maybe like a small group. Or if some students want to present in the common group, yeah, you can present. But I will do some case discussion classes. Say for example, in one class I can do maybe 5 or 6 case discussion. So if you do 5 classes, so you are going to expose to 30 case presentation, whoever present, whoever present. So you will get to know how to take history, what are the mistakes you can do, what are the question examiner will ask, how to approach the patient. Because every patients are different. I will teach you now, right? Every patients are different. How difficult to take the history, you will understand. So at least you need to know how to take the history. I will correct it, so then you can apply that concept to your patient. Got it? So you have to get practice, because you are going to get only 7 minutes for the history taking and examination. So within that 7 minutes, you don't have time to think. So everything should come in reflex manner. So once you come to the class, I will tell you, you have to record your history, listen your history, then only you will realize how horrible your history, right? How the examiners are suffering by you, right? Always you have to listen your history, right? Present in front of the mirror, right? So your body language, facial expression, right? So everything is very important. Okay, right. And so as I told you, the stage 1 and stage 2, I will teach you how to do the classes. And uh, after that we'll do some case discussion with the patient. So even I'm planning to do like so you are not going to miss the hospital visit, right? So we are going to conduct all the classes in hospital, right? So uh, I'll bring the patients here, right? So one of you can take the history from the patient. So lively we are going to discuss with the patient. So then you will get to know how difficult to take the history. So each and every case, you can take the history. Even if you couldn't find some rare cases like SLE, then I will be the patient. You can take the history, right? I will give the history. Then I will correct you how to take the history, right? And of course, and I will do the live examination demonstration. Yeah, here we can do. Yes, yeah. So we will do the live demonstrations. So then you can get practice how to do the examination, what is the correct technique. Then maybe later part of February, once this corona part is over, anyhow, uh, we will arrange the practical session. So somewhere, or maybe in the hospital. At least I'll try to correct yourself while you are doing the examination. This is my plan. Okay. And one more thing I need to tell, when we have Viva. Okay. So I can tell you one. So last time the repeat batch internship they have taken in the early part of May, right? So this time definitely they have to take maybe in the May, so early part of May. So then your exam should finish maybe early in August, April. So probably uh, in the mid part of March or later part of March, high chance to have your Viva. So you have very limited time. Within that time, you need to get practice. So I can teach you the techniques of history taking approach to the patient. So once you come to the class, once I teach you how to approach the patient, it's applicable for other subject as well, because um, obviously the patients are same. So you can apply those principles to the medicine patients, to the pediatric patient, to the surgery patient. So same thing, but the different component you may have to ask. So if it is a MI, your question might be different. But the approaching the patient, developing rapport, right? Gathering information, identify the main point. All these techniques are same, right? So I have a lot of experience, even a lot of students, senior students who failed several times in past. So usually this is so my Viva classes most. If I have 50 students, right, earlier, if I have 50 students, around 45 will be uh, uh, the second attempt or third attempt, only 5 freshers. But 45 people will get through the exam. That is how usually 90-95% will pass the exam. The reason is this is not depend on the shy. So why they fail? They have enough knowledge, but they don't know how to take the history, how to present to the examiner, right? So they might be tense, right, anxious in front of the examiner. They don't know what to ask, how to ask. So then it might be the reason for the failure, right? And the stage one, stage two, followed by case discussion. That is, even I will arrange it like a group or individual or common discussion will be there. But I will make sure all the exam batch students will get the chance to present the history. That is one. And third one, I'll do some instrument and the emergency Viva preparation as well. That is with the case discussion. I will do it, right? Maybe in the mid part of February, right? And the students who are coming to my stage one, stage two will get the priority to present the history during the case discussion, and even I plan to give the price reduction for them as well, right? Okay, fine. And we what I thought today is we will take the history, a random history, right? So I have one patient. She can talk Sinhala as well as Tamil. So we will just I'll give 5 minutes to a student who can take history in Sinhala. Then I will give another 5 minutes for students who can take history in Tamil. So this is how I'm going to do it, right? So and also I will give the notes, that which notes will contain the history in English, Sinhala and Tamil. So the Sinhala students who can take history in Tamil, and Tamil students who can get practice in Sinhala, and which will contain the examination, investigations, management, and discussion part. There are the possible discussion questions with the answer, right? So even during the class also, you can take history in Sinhala as well as uh, Tamil. So then everybody will get used to the language also, because uh, in Viva, right? So the passing the Viva will be determined by different facts, right? So different fact determining the Viva pass rate. So can you just, somebody can tell me what are the factors determining your pass rate? Anybody? Yes, Nartana. What are the factors determining the pass rate? Yeah, anybody? Confidence, okay. No, not the confidence. Okay, yeah, that is also, yeah, confidence. So it's very simple. One, your knowledge. Second, your communication skill. Third one, as you said, your confidence. Yeah, and fourth one, your rational way of thinking and giving the management plan. So how you are applying your knowledge, how you are reproducing your knowledge to the patient, right? So these are something related to your knowledge and skill. So beyond this knowledge and skill, there are other factors which is determining your pass rate. One, the mood of the examiner. If the examiner has a problem with his wife previous day, then that will affect your exam. Yeah, agree? Mood of the examiner. That is one. Previous candidate, very good. If the previous candidate did well, then next person will die. If the previous candidate did very worse, then even though you do average, then examiner will think, oh, poo, he's a brilliant. So it's comparison. So the previous candidate. And third one is the exam, right? So if you are the first candidate, then examiner is very fresh, and patient is very fresh, and you are fresh. So then everything will go smoothly, right? But with the time, maybe at 4 o'clock, 3 o'clock, then examiner is getting tired. He is not concentrating your history. Sometimes even you tell something, uh, uh, he might say, no, you didn't tell, because he couldn't concentrate. And maybe near to 3, 4, he might think about his private practice. Oh, 4 o'clock, I need to finish this exam, bloody exam fast, and I need to go. So then it might affect. So there are so many factors beyond your hand. You can't correct this. You can't correct this. So then what you have to do is, you have to bring the examiner's attendance to you as well. So that is also one of the art in the exam. So if the examiner is not concentrating, then you have to tell something in 2 times, 3 times. So maybe sometime you can't present in a monotonous way. This patient presented with vaginal bleeding for 3 days. Then examiner will sleep at 2 p.m. So sometime you may have to increase your voice. Yeah. So when I am examining this patient, then even if the examiner is sleeping, suddenly he will get up and see, yeah, what he is telling. So those are the things you need to learn. So this is not the book things. So this is an art. Get practice, right? So of course now almost 800 students are there, but I can keep you awake without sleeping. So I know what to tell, what not to tell, right? So another thing I'm telling, throughout this course is going to be very funny, right? Because you people will get to know how, because the patient will give some funny things to us, right? So they will tell some very, very funny things. And yeah, of course, and students, the person who is presenting will give a good entertainment for us. So we will have a good time during the course. Okay, right, fine. So anyhow, don't worry about the things. At the end, you have to have a good knowledge. Okay, now we will have a small demonstration with the patient. So you can take the history from the patient in Sinhala. Anybody? I can give a chance to one person, whoever, volunteer. Yes, Amaru.
So I will take.
Okay, okay. Yes, come in there. Good evening.
Good evening, sir.
Yeah. So you can talk to this patient. Right. Okay. You can ask question from in Sinhala. She'll answer. Then after that we can let one student to ask question in Tamil. Then we will discuss in English. Okay. So speak loudly. Okay.
Good evening, sir. I need your consent to take a history from this
No need
patient.
to take consent from me, because this patient is not belongs to me. I can't give consent on behalf of this patient. Okay. Yeah, of course I am responsible for this patient, Kavinda, but patient itself need to give the consent. So just take the consent from the patient.
සුබ සන්ධ්‍යාවක් අම්මා මම මේ අවසාන අවසර වෛද්‍ය ශිෂ්‍යයෙක් මම අද විභාගයක් සඳහා ඇවිල්ලා තින්නේ මම අම්මගෙන් ප්‍රශ්න කිහිපයක් ඇහුවට කමක් නැහැ නේද අම්මගේ රෝග ඉතිහාසය ගැන
Yeah, you can answer. Single address.
අම්මගේ නම මොකද්ද
Yeah.
අම්මගේ නම මොකද්ද
නිරංජනී
වයස කීයද
26යි.
අම්මා කසාද බැඳලා තින්නේ
ඕ
හරි අම්මා ජොබ් එකක් කරනවද රස්සාවක් කරනවද
Job.
කාමස් කෙනෙක් කරනවා.
අම්මා ගෙදර කොහෙද ගෙදර පදිංචිය
What is done here?
අම්මා මේ පාර හොස්පිටල් නවතින්න හේතුව මොකද්ද
Okay, actually she's a bit shy to talk in front of camera, because Sinhala is not good. Anyhow, I'll tell something, or translating her what she's telling. So she's a pregnant mother admitted with vaginal bleeding. Okay.
අම්මා අම්මගේ මාසික සුද්ධිය පළවෙනියටම උන දවස මතකද?
எப்போ கடைசி period உண்டு?
10 மாசம்
So October
October
15th.
අවසාන මාසික සුද්ධිය අවසානයට උනේ?
So when you talk to the patient, sometimes if the patient is not okay, you might get the patient like this. When you talk to the patient is not happy to talk with you, or not understand what you're asking. So what are you going to do then? This is how we are going to practice it. So what we are going to do then? Now you're asking the question from patient, but patient is not understanding. So what are you going to do then? Yeah, Kavin, what are you going to do then?
Anyhow,
Call nurse. So calling nurses and having contact with the nurses is not acceptable during the exam. So who is that person who want to call nurses? So you can't rely on the nurses. So what you have to do is, if the patient is not understanding your knowledge or your language, then you have to ask in a simple word, right? So this is going to happen when you are talking with a patient in the other exam center. So if you get this exam center in maybe in Trincoma, Baticalo or Jaffna, so then you are going to get Tamil patients. So sometimes when you are talking, even you might remember some words, but your pronunciation might not correct. So then people will not understand. So if of course it's happening to me when I'm talking with the patient in Sinhala. So they are not understanding what I'm asking. So then the same question will be asked by my house officer, then they are answering. So this is how people suppress my Sinhala. Okay. So the same question I'm asking, but the patient couldn't understand. Why? Because my pronunciation might be wrong. Of course, I know. But when somebody asks with a good pronunciation, patient might answer. Okay, right, okay. So actually, she got admitted with the pregnant mother. She got admitted with vaginal bleeding. Her LRMB was 15th of October. And she had a regular period. So what else you want? You can ask. So if you want, I can translate it. Yeah. What else you want?
I want to ask about he has pain or not.
Okay, right. So you want to ask whether patient has pain during the menstrual bleeding, right?
Yeah.
Okay, fine. Kavinda, this is the thing I'm going to teach you, right? So if you want to talk to the patient, you can talk to the patient for 24 hours. You have a lot of things to talk. Right? You can ask about the pain, you can ask about the vaginal bleeding, you can ask about the pad, whether it's fully shocked or not, whether she's having a problem with the sexual life, whether she's having pain during sexual life. So, and there are so many things to talk with the patient. Now, you have been given only 5 minutes to present the history. So within that 5 minutes, if you ask something that should be relevant to your case, right? And you should be able to identify the main problem and associated problem which she is having, and you need to treat that. So if you are going to talk something for 5 minutes and finish it off at the end, of course you talk to the patient for 5 minutes, you are presenting for 5 minutes, but you are not taking the important information. You are not identifying the core problem. You are not treating the patient properly. So every time when you are asking something, every time when you are doing the examination, if I am touching the patient like this, I should know why I am touching. So without knowing the reason, can I touch a woman? What do you think, Kavinder?
Sorry, sir.
Without a reason, can I touch a woman?
No, sir.
No, you can't. So whatever you do, whatever you ask, you need to know why I am asking. So my question, so this patient, a pregnant mother admitted, what is the reason for the admission?
yellow color period.
Okay, she came with the vaginal bleeding. So we are asking some question, right? So you're asking about dysmenorrhea. So my question, what is the significance of asking dysmenorrhea for a patient, pregnant mother with vaginal bleeding? Is it relevant to ask? This is the question.
No, sir.
right? So you can't ask, you can't talk to the patient. Just so of course, if it is so, when you talk to your girlfriend, you are talking overnight for 3 hours, 4 hours, 5 hours. At the end, you just see what is the summary. Nothing. You can talk with anyone for a long time, but there should be a reason why you are talking. So if you ask this, you should know why you are asking. Is it relevant? Will it help? Will this help you to diagnose the disease or to manage the patient? Got it? Without the reason, you can't talk it. So next, so always, so I'll try to bring the Sinhala patient as well as Tamil patient. So every time you have to ask the question. So I will give 5 minutes to take the history. Within that 5 minutes, whether you gather the important information or not, that's the thing I'm going to teach you. Got it? Because at the end, you have to know all the problem, right? Okay. So anything you want to ask, Kavinder? No
Yes,
worries. No worries. If you do mistakes, because this is the why I bring the patient, why I want to ask you the question is, I just want to show how much you are deviating from the important thing. That's it. But when you take the history, you should have a background knowledge. If it is a GDM patient, what are the relevant information I need to ask? What are the things I need not to ask? If it is a hypertension patient, what are the things I need to ask? What are the things I need not to ask? So those things we are going to study in stage 1 and stage 2. Then, now this patient is presented with pervaginal bleeding. A pregnant mother presented with pervaginal bleeding. So are you going to treat this pervaginal bleeding, or are you going to treat, what is your name?
Niranjani.
Niranjini. Are you going to treat Niranjini, or are you going to treat patient with pervaginal bleeding? Yeah,
need to
Kavin?
treat Niranjani.
Yeah, you want to treat Niranjini. So that's why I'm always telling to the students, you will not get any case in the exam. Will you get case in the exam? No. There is no GDM case in the exam. There is no PIH case in the exam. There is no fibroid case in the exam. What I'm trying to say is, there is a pregnant mother with multiple problems. So one of the problem is gestational diabetes mellitus. So you will not get a single patient with pure and simple diabetes. Pregnant mother, first baby with diabetes. Then, of course, it's a diabetes case, but it's not a diabetes case. It's a pregnant mother with primary and gestational diabetes. Maybe complicated with polyhydramnios. Sometimes you might get a patient IgGR, past section, and hypertension. So then, if it is 3, 4 problems, then which case you are going to take the history? Which one you are going to take? So when we are discussing through these classes, I will let you know. Some patient might have several problems: diabetes, hypertension, IgGR, past section, and anemia. So there are 5 problems this patient is having. So if it is 5 problem, what is the case? Are you going to take the GDM? Are you going to take the PIH? Are you going to take the past section? Are you going to take the IgGR? Are you going to take the anemia? Which case is this one?
Sir, I need take a major case.
No,
What we
that is the wrong concept. You have to change it. There is no major case and minor case. What you are going to do is, you are going to take the history of Niranjini with problem. So at the end of the history taking, you should have a problem list. So what is the problem list? This pregnancy has, I identified following problem to this mother. She is a diabetic complicating pregnant mother. She is hypertension complicating pregnant mother. She is anemia complicating pregnant mother, and baby is IgGR, and also its past section complication. So considering all these complication, all these problem, how you are going to manage this patient from today until delivery and after delivery. That's it. So you have to take the history of Niranjana, not the history of GDM. You have to take the history of Niranjana, not the history of anemia. There is no case in obstetrics. Not only obstetrics, everywhere, but in obstetrics and gynecology, there is a no case. There is no GDM case, no PIH case, no IUGR case. Pregnant mother with problem. So, at, at the end of the history taking, at the end of the history taking, you should identify the problem list. You should have a summary. So just imagine how difficult to take history for all these complications within that 5 minutes. That is the thing we are going to learn, how to identify the problem. So within that 5 minutes, you need to identify all the problem. You need to ask question regarding this problem, and you need to have a plan how you are going to manage this patient. So if somebody has 256 or 512 RAM, please, you can change your RAM to 4 GB or 8 GB. Okay, because your brain should be should function very fast. So while you are asking the question, you have to think the next part. While you're asking, okay, she's having this problem, so then what you are going to ask next? So you can just talk. So I have seen so many patients or so many students how they are presented. So so in the first class coming 16, I will teach you what is history taking, why we are taking the history. So I'm going to do like one class per gynecology history taking and examination, one class per obstetric history taking and examination. The reason is that one class is going to stay with you until you stop your practice. That is an art. That is a the way you approach the patient, how you are approaching. So you need to know how to think, what to do, what to ask next, right? So what is the difference between the theory and the Viva is a retrospective application of your knowledge. Is the Viva, right? So now this pregnant mother presented with pervaginal bleeding at POA of 13 weeks. Pervaginal bleeding at 13 weeks. Now, what you are going to think is, what could be the reason? Why she presented with pervaginal bleeding at 13 weeks? Right? Why she presented with pervaginal bleeding at 13 weeks? There could be several reasons for that. Right? It could be a threatened miscarriage. It could be an incomplete miscarriage. It could be a complete miscarriage. It could be a trophoblastic disease. It could be ectopic pregnancy. Or it could be a vaginal trauma. It could be an infection. So there are possible causes for the pervaginal bleeding. Now you are thinking with the symptom, what are the possible causes? But in theory class, what did you study is, you study miscarriage. When you study miscarriage, what did you study? Miscarriage can be presented with pervaginal bleeding and abdominal pain. Right? Then when you study the trophoblastic disease, you study trophoblastic disease might present with pervaginal bleeding and abdominal pain and passing grape-like structures. When you study ectopic pregnancy, you study ectopic pregnancy might present with pervaginal bleeding and abdominal pain. Now, this Niranjana, it's not going to tell to Kavinda, hello, Dr. Kavinda, I am a pregnant mother, 13 weeks, and now I'm having bleeding due to incomplete miscarriage. Can you do something for me? Agree? So she's she's not going to tell you, doctor, I'm having this problem. So in the theory question, they said like that. The Niranjana, 26-year-old Niranjana, mother of one, delivered 6 years back. She's pregnant, presented with pervaginal bleeding and passing clots and product at a POA of 13+6. You are the house officer. What is the next step of management? So then all the extract information has been given to you. Yes, you are thinking about the management. But now here, the Niranjana did not tell anything. You have to collect the information from Niranjana. Got it? So you need to ask from the patient. So patient is not understanding what you're asking. So you need to ask whether the patient, in a language where the patient can remember. Can understand. Got it? So the Viva, it's going to be a retrospective way. Now patients are going to come with the symptoms and you are going to search the cause with the symptom. If it is a heavy menstrual bleeding at 16 years, then what are the possible causes? Then you are looking those causes. If it is a Pervaginal bleeding after menopause, postmenopausal bleeding, then what are the possible causes? Could be a infection, cervical CA, endometrial CA, or polyp, or so atrophic vaginitis. So we are looking in the other way around, retrospective way. That's what I told you. The history taking is an application of the knowledge and reproducing your knowledge to the examiner and your clinical practice. This is not for your ERPM only, for your clinical practice. Now, when the Niranjana is telling something to you with pervaginal bleeding, now you are going to apply your knowledge and you are going to think what could be, why is she present, why this Niranjana came with pervaginal bleeding. So if you are thinking it's miscarriage, then you need to think why she developed miscarriage. What could be the reason? Is it a preventable thing? Can I prevent next time? So that is how you are managing. So just managing symptomatic, it's not the way. I will share some clinical experience. So what are the mistakes we have done throughout our career? What are the mistakes we came through the careers, and then how we correct ourselves, how we are preventing those kind of things in our day-to-day practice. So that is your Viva, that is your clinical practice. This is not for the exam purpose only. So it will make you a perfect and good doctor, right? So you are going to be a smart doctor. When you are working in the ward, others should respect you. That is not because you are scolding. The way you are behaving, the way you are thinking, where you are managing. So if you do the proper management, actually you don't want any advertisement for your private practice. Patients are the advertising people. So if I am teaching properly, I don't want to put any kind of advertisement in the group, WhatsApp or Telegram. Why? Because you are the people going to tell your juniors, yeah, you can go to his class. Don't go to this bloody teacher's class. He never taught anything. He's talking something else. So you are the people going to be the good advertising persons. Patients are the good advertiser for you. And this is not the money matter, I'm telling. Right? So always people will respect you the way you are managing, way you are behaving, way you are approaching the patient. So so today we had a patient with cervical CA, right? So she had stage 2B cervical CA. So how I am going to disclose the condition? How I am going to tell to the patient? So you are having cervical CA stage 2, we can't, stage 2B, we can't do operation, we have to do these things, these are the complications. But at the end of the counseling, at the end of the discussion with the patient, when the patient is leaving from the ward, she didn't cry. But I didn't hide anything, but she didn't cry. She said, okay, thank you. At least we found this time, it's okay, doctor. We will do something. So that kind of communication. So how to communicate with the patients. So at the end of consultation, at the end of consultation, at the end of meeting the doctor, the patient should have some kind of confidence or some kind of relief. Okay, I got some relief from this doctor. So this is not only the knowledge, actually this is going to be the career, your way of teaching, way of treating the patient. Okay, so how to take the history, how to gather information, how to identify all the problem, right? So Kavinda, do you want to ask any question or anything, something related to this patient, or to identify something?
I need to ask, she has any fever and she has any pain, or she has still.
சொல்ல போறீங்க சொல்லுங்க. Okay, right. Actually, she doesn't have pain and she doesn't have fever, right? Kavinda, unfortunately, your video is not coming, so she doesn't like to tell to my computer without seeing the doctor's face. Okay, doesn't matter, right? Anyhow, she doesn't have fever, she doesn't have pain. So, anything you want to ask?
Still, she has bleeding, sir.
Yeah, she has bleeding, of course. That's why
she has passed any clots like something.
No, anything.
Okay, she has a baby
or not? Yeah,
Sorry?
it's bleeding. So somebody is asking, was it a fresh bleeding? Yeah, of course, it's fresh
Yeah.
bleeding. So in the exam, Kavinda, you don't have time to think, right? Within 5 minutes, you need to identify all the problems. So yeah, you missed the major part, right? So what is the POA? Right? So, okay, she's 13 weeks pregnant, right? So she came with pervaginal bleeding. So could it be a criminal abortion?
Can be, sir.
So then what is the first question you need to ask?
It is a planned pregnancy or not?
No, if it is not if it is not a planned pregnancy, they want to do termination, right? So I'm not agree with that planned or not.
Is
Is
she
she
married
married
or
or
not?
not?
It's
Married?
a no.
Married or not?
Even people are nowadays happy to deliver the baby without marriage. So what is the question you want to ask?
Does she need a baby?
Very good. Is it a wanted baby or not? That's the question. It's a wanted. So this is how we are going to talk to the patient. So you can't talk unnecessary things. So simple one word. This baby, was it a wanted pregnancy or not? If she's telling no, I didn't marry, I don't want this bloody baby. Still, I didn't complete the ERPM, so it's something misfire. So then definitely they will go to the termination, right? So the simple question, this baba is wanted or not? The one question you can have a good idea. If she says yes, it's a wanted, then second question you can ask, okay, have you planned this one? That is the second question. So this is how we are going to talk to the patient in a way, right? So I'm not talking too much, but I'm talking the very relevant to this patient. With single word, right? I'm gathering a lot of information. So in the baby, in the tribe, so they were trying for a baby. So what do you think? They were trying for a baby. She's
It is
married.
not a criminal abortion.
Sorry?
It is not a criminal abortion, no?
You can't say, still you can't say criminal abortion or not. But it's a wanted pregnancy. So then criminal abortion is less likely. Right? So here, when you take the history, I will teach you the component of the history, history presenting complaint, history of presenting complaint, in the history of presenting complaint, symptom analysis, right? Exclusion of differential diagnosis, identification of risk factor, complication, then objective assessment. So they are a format. I will teach you that. So if you analyze the symptoms, then you can have a differential diagnosis. So she has these kind of symptoms. So these are the possible causes. Right? These are the possible causes. So then among the possible causes, what could be the main cause? So then you are asking some specific question to identify the main reason. Got it? Anything else? Anything you want to ask?
I need to know about the para and gravida and also
So she delivered only one baby 6 years back. Now this is
so
a second
no
pregnancy.
has same history like this, sir.
No. This is a second.
Previous history.
This is a second pregnancy.
Second one, no? Okay.
So actually, I will teach you how to write that G, P, C, those things, and how to calculate the EDD, how to calculate the POA. So this Viva class is going to be like the scholarship class, not like the theory class. So in theory class, I'm just talking, and you people are eating something and drinking and seeing whether I'm teaching very well or not. So in between, when you get bored, you are typing something. Sir, why is that? Can you send this presentation? Those are the things. So, but Viva class is not going to be like that. So I'm going to give some work. Okay, calculate this EDD, calculate this one. So it's going to be an interactive class, right? So then only you will not forget anything at the end of the course. Right. Okay. So now, anything else? Oh, it's a second pregnancy. Okay. Anything else you want to ask?
18 scan done or not?
Okay. Done.
Mhm.
Blood group. Okay. Blood group is O positive. Why you want to ask the blood group? What is the
Because
significance? Why you want to ask the blood group?
in case of the ectopic pregnancy, it is rupture done, need to blood transfusion, no? Stabilize the patient.
Okay. Right. That may be more than that.
Give the RH negative.
Very good. That's the reason. So if the mother is Rh negative, this is the fetomatic, this is the chance for the sensitization. So then you may have to give the rogam. Now you can understand now, right? So even with the miscarriage, there can be a chance to discuss about the Rh negative. So that's why I'm always telling there is no case. There are patients with problems. So what is the problem? So this Niranjana with threatened miscarriage and Rh negative. So then how are you going to manage? So baby is active, so I will give the rogam. To prevent the miscarriage, I will give the progestin cream or progestin injection. So now you are managing Niranjana to her problem. So now what I notice or what I find in your history is, right? So you are always concentrating only the pervaginal bleeding and the pregnancy history, but almost it's 15 minutes gone, but still we are concentrating the pervaginal bleeding. So is Niranjana having any other problem? Any other problem? So if you are talking with particular problem for 5 minutes, at the end only, right? So when they are calling for the discussion, that time only Niranjana tell, doctor, I had thyroid disease also, and I am taking carbimazole. Also, I am having epilepsy. And when I am coming to the clinic, first clinic, they did the OGTT, it was very high. Now, what are you going to ask about that question now? Because at the end, when they are calling only, you found she's having some other additional problem. So then, how can you overcome this problem? How can you identify all these problems which she's having at the beginning? Because if you identify all the problem only, you can organize your history and you can ask question from the patient within that particular time. So here with what we are going to discuss and get training is, one, you are applying your knowledge, you are going to develop the communication skill, you are going to develop the good rapport, developing rapport, right? And you are going to develop the organizing history and presenting the history in a way, and you have to plan your management, right? So the examiner finally they will ask, okay, so what are the problem you identified? So I identified this patient is a 26-year-old second para with one living child delivered vaginally 6 years back, is a wounded pregnancy, presented with pervaginal bleeding without abdominal pain for 1 day duration at a POA of 13 weeks. Also, she is Rh negative mother. She received rogam after admission. So this is the summary. So your summary has all the information. So if you present like this, then examiner will not ask anything from you. If not, if you say something, then examiner will start to ask some question. So I'm always telling to my student in the exam, what you have to keep in your mind is always you have to keep the ball with you. Don't pass the ball. Don't give the ball to the examiner. Then if you give, then that is the end, because we don't know what they are going to ask. So always keep the ball with you. That even the examiner took the ball, immediately you have to pick the ball back. So I will teach you how to pick the ball back. That is an art. Right? So you can track the examiner. Sometimes patient might have, okay, as I told you, patient might have diabetes, hypertension, IUDR, past section and anemia, but you are not sure about the past section management and anemia management, but you are very good in diabetes management. So then you can easily manipulate the examiner and you can track the examiner to the GDM part. So I will teach you how to do that. That is an art. That is the way of passing the exam. You can't just tell this patient is past section and anemia, then examiner might interested in anemia, then you are done. Got it? So this is an art, how to present, how to prevent yourself. So otherwise it's going to be casualty, disaster. Isn't it? So it's going to be a disaster. So you have to prevent the disaster. Because basically you all are going to be obstetrician. So what is the other name of obstetrician? The person with rational thinking. Isn't it coming there? I don't know about the other people, but obstetrician always thinking in a rational way. Have you done it? Yeah, patient also telling like that. Right? So you have to be a rational person. Even when you are talking to the patient, you have to be rational. So what you can do, you can simply ask, okay, Amma, why did you come? So there are a few questions. So one is closed question, another one is open question, right? So what you could do is you could ask 2-3 open questions. Amma, why did you come? What are the other problem you are having? Then patient might say something. Then you can ask closed question to fulfill your history. So in the closed question, you need to control the patient. You have to take the power. You can't let the patient to talk and you can sit and waiting for your information. Then you have to take history for 1 hour. Say, for example, so patient might come and say, so patient might present with chest pain. So when you're asking, why did you come? Patient will say, doctor, yesterday I went to my eldest daughter. That daughter's husband is not good. No, he is always making problem with my daughter. So then yesterday evening when I'm going, they were fighting. So then I got tension and I went there. Then he started to scold me. Then I suddenly got shocked. Then I developed chest pain. Why she told this much of bullshit? Because she is going to explain why she developed chest pain. But the initial part is not relevant to you. So then, but you can't tell them, stop this. Tell, why did you come? You can't tell like that also. If you tell, then the rapport will not be there. Then you can't take rest of the history. Then patient will be, you might say, no, so if your girlfriend is telling something, oh, this is like that, so she might need to buy a sari or something, and then she might explain, my friend yesterday, it's that yellow color flower is very nice, no? Then you should know what she's going to tell. So then you have to nicely listen, okay, so then do you like to buy that? So then it's finished. So I'm going to their line and just you should know what they are going to say, what they wanted to say. So I'm not. So if your girlfriend is telling, so that is beautiful like that. If you say, hey, stop this, what you want? So then it's end. Then there won't be any SMS for 3-4 days. Am I right? So you need to know. So that's why the first class I told you, obstetrics and gynae is very difficult. Why? You can't understand simply. Like the woman, you can't understand the woman easily, but once you understand, it's very easy to manage. This is applicable for your girlfriend as well. If you understand your girlfriend, you can easily manage. It's not a big thing. Up or no? So somebody got affected. Right? Okay, anyhow, right. So Kavinda, anything you want to talk to this patient?
I need to take a medical history and family history also, sir, because
okay. I will tell you once. So today it's not enough to explain each and everything. What are the medical history need to ask? So most of the time the students are thinking. So there is a format: presenting complaint, history of presenting complaint, past medical history, past surgical history, allergic history. So then they need to fill all those blanks and they need to present. So that is not the meaning of history. That is not the meaning of history. History, if you take the history, if you are presenting the history at the end, so that should be a nice summary. So even sometimes you might skip something. even the allergic history. So you can simply say her past medical, past surgical allergic history is significant, not significant. That's it, right? So you can't just, okay. I'll tell you some experience what has happened when I'm starting this Viva class. So I have a lot of experience with this history presentation, not only the ERPM students, also even the postgraduate students, right? So I'm very famous to bite the students while they are presenting the history, right? So so one day one student is presenting like for the heavy menstrual bleeding. He or she, I forgot. So that student is presenting this patient, 56 or 46-year-old mother of two, presented with pervaginal bleeding, menstrual bleeding. It's regular heavy bleeding, and she went to Kalabovila hospital, and they have done the scan, and scan was normal, and they have given some tablet. With the tablet, bleeding was settled for 2 days, 2 months. Then again she developed pain and bleeding, and she went to DMH, D Soisa Maternity Hospital. There also they have done the scan and it was normal, and they have done the DNC also normal, and again they have given the drug, and patient went home, and for 6 months she doesn't have any problem. Again now she developed bleeding, and she came to Castle Street Hospital. This is the history was presented by a student. So at the end of the history present, of course, the student has talked to the patient for a long time, and patient given a big history about the bleeding, what has happened over this time, right? And the student also happy. She took the history for a 15 minutes, and she could present this history for 5 minutes. But at the end, what is the reason for the bleeding? You took the history. What is the reason for the bleeding? If somebody go to Kalabovila and settle for 2 months, what are the causes? Even if they go to second time, go to DMH, what are the causes? Simple. So at the end of course, that is also history. Your patient's menstrual history. But at the end, what is the diagnosis? What is the diagnosis? This is how most of the people are presenting the history. They are talking to the patient. They are presenting what the patient is telling to us. What is this history taking? The history taking and presentation is a discussion between two professionals, right? So Kavinda is a doctor. I'm a doctor. Kavinda is discussing about a patient with me in a professional way. You can't tell what patient is telling to me. Tell you. So then, what is the difference between Niranjana and Kavinda? Then Niranjana also can start a clinic and do practice. Isn't it, Niranjana? Right? So then you have to show the difference. I'm a doctor. I'm talking about my patient. That should be a professional way. What patient is telling to you, if you present to me, then nothing. So that is how we need to get practice. So how to gather information and how to discuss with the professional about Niranjana. So you should know what are the things I need to tell. You should know what are the things I should not tell. Right? So Niranjana will not tell each and everything which needed for the management and to the diagnosis. She doesn't know anything. She doesn't know anything. What else? What to tell? What not to tell? She don't know. So you have to analyze. You have to identify what are the information, additional information I need. What are the things I need to ask? So sometimes Niranjana might concentrate something, then you can say, okay, fine, I understand. But so when you go to Pudukudi, you develop bleeding. No, so during the bleeding, have you had pain? So I'm not stopping Niranjana. I'm going through with the Niranjana and getting the information. Okay, I agree. So when you have bleeding, have you had pain? So have you passed anything? So then Niranjana might start, oh doctor, when I go to Pudukudi, I was in a textile shop. Then I had heavy bleeding. Then I asked the textile person, do you have washroom? Then I was searching the washroom. Then she will go somewhere. Then you have to drag the Niranjana. Okay, right. So then still you have same bleeding like that. So now you are diverting the Niranjana. You are tracking the Niranjana towards you. So, have you had any abdominal trauma or abdominal injury or something prior to start bleeding? So you are just diverting, and you are not inhibiting, or you are not stopping the Niranjana's flow. Also, at the same time, you are gathering your information with her frequency. That is the history taking. Got it? Got it. So then you have to have a plan, organize your history. I will teach you how to gather information, how to. So there are formats, right? So translation, interpretation, analysis, organization, summarization, presentation. So it's a process. For the history taking and presentation, it's a process. So you can't just take the history, translate, and present. You can't do that. I will teach you when we are studying. So that's why I need 4 hours to teach how to take history, how to analyze, how to interpret it. When Niranjana is telling pervaginal bleeding, you have to interpret it. Is it really bleeding? Sometimes it might be a pervaginal discharge. First, you need to interpret it, what she is telling. Is it really a disease? Then you need to analyze why, what could be the reason. I will teach you. Then you need to organize, gather additional information. Then summarize, plan your management, and present to the examiner. Don't give the ball to the examiner. Yes, anyone want to take history in Tamil? So for just
I'll take, sir.
okay, you can ask. I will be the translator, English translator. Right, okay.
அம்மா நான் இந்த
She might
final
she might scared about me because I'm very closer, no social distance. I don't have mask. She's very concerned about her corona status. Papering, look. Okay, right, fine. Right.
ஹலோம்மா, நான் எக்ஸாமுக்கு வந்திருக்க ஃபைனல் மெடிக்கல் ஸ்டூடெண்ட்மா. உங்களோட கொஞ்சம் காய்ச்சி உங்களோட கர்ப்பத்தை பற்றி கொஞ்சம் கேள்வி கேட்டா பரவாயில்ல உங்களுக்கு?
கேள்வி கேட்டா ஓகே.
ஓகே, உங்களோட பேர் என்னம்மா?
நிரஞ்சனா.
எத்தனை வயசும்மா?
26.
Right. So now you have told you are a medical student. You want to ask some question. Is it okay? Now this poor patient is respecting you and said yes. But if you ask from me, then I will ask, why are you asking? What is the purpose of asking? Why I want to tell you? What is the reason? You want to put it in the Facebook? I met one patient today, so she has this problem, feeling happy or feeling crazy. So there are way to take the consent. So what are the components should be in the consent, right? So in the exams, actually your examination technique, so you might think if you present the history you are safe. It's not like that. In the I will teach you the component of the history, how they are assessing, how they are giving the marks. So even if you don't have knowledge, even if you are not answering, still you can pass the exam, because there are so many components. So your communication, making rapport, right? So taking consent, gathering information, organization, summarization, plan your management and presentation, then your examination techniques and findings. So your finding might be wrong. So even in postgraduate exam, part 2 exam, right? One of my colleague missed breach. He missed breach. He said it's Hebelic presentation, and he presented as Hebelic presentation, but still he could pass the exam. What they say is 50% of experienced consultant will miss the breach with the examinations. So the examination, if you miss something, you will not fail. You will not fail. But there are something not to miss. I will teach you what are the things you should not miss. Those things. So if it is a floating head, you can't miss because you are a dangerous house officer. So something you can miss, right? So what they are assessing is they are assessing the techniques. So even if you miss some part, still you can pass, because your finding, your examination finding might carry 10 or 15 marks only. So you are going to miss only that 15 marks. Rest of the 85 still there. If you do that properly, you can pass. So I met one student who failed the exam previously. I just have a chat. She came to my class. So she failed previous exams. And then I asked, okay, I used to ask, why did you fail? What was the case? Then she told, actually, sir, I missed the lie of the second twin. And the examiner got mad and failed. So do you think that may be the reason for the failure of exam? Obviously not. Even if you miss the lie or if you miss the twin in singleton pregnancy, you won't fail. Then how can you identify the lie of the second twin? It's even I can't do that. So we do the scan to find out the lie of the baby. So at least you need to know the fundus is more than the date. The abdomen is bigger. It's a multiple pregnancy. That is the only thing. So then you can say, as it is a multiple pregnancy, fundus is more than the date, I need to do the ultrasound scan to confirm the lie of the baby and the presentation. So even for my part 2 exam, I got a breech and obesity. Breech and obesity. The morbid obesity, BMI is 38. Right? So I did the examination. I checked they checked my techniques. When I'm presenting, I told them, this is my morbid obese patient, so I couldn't measure. So the symphysiofundal height is not appropriate to the period of gestation because she's having a big fat pad. It's not appropriate, and because of the obesity, I couldn't find the lie and the presentation and engagement. To confirm that, I need to go for ultrasound scan to check whether it's a cephalic presentation or and the lie. That's it. I still passed the exam in first attempt. Because you will not fail because of that. You have to understand that. Right? So always what you are thinking, I fail because of that. Actually, you are not failing because of that. You are failing due to some other reason. So my duty is to identify why you are failing. What could be the reason you might fail? So then I need to correct it. Then only you can pass the exam. Okay. Yes. Go ahead, Jidu.
ஆமா உங்களோட சொந்த இடம் எங்கம்மா?
Okay, so even when you're asking in Tamil, she couldn't remember. So she couldn't understand. So please, so when you talk to the patient, you have to talk the way patient can understand. So now you can everybody can understand. This is not the problem with the language. This is the problem with the way of talking. Actually, I took her to the class because she told I can talk Sinhala very well. I can talk English, Tamil very well. So then that's why we took her, because particular patient can talk both language. It's easy for us. But in the class, she couldn't understand the Sinhala. Then I thought she's not good with the Sinhala. Now again, she couldn't understand the Tamil as well. So it's not the problem with the patient. It's a problem with the student. So this is the reason I just want to do the case presentation. Then only everybody will understand what are the possible mistakes you can do, how to correct it. So Jidu want to ask, where are you? Where are you living? What is your living place? You're asking in Tamil. She is Tamil, but she couldn't understand what you're asking. So where is the problem then? The problem is with your way of communication. So Kavinda, now Kavinda it's feel better, right? Okay, right, go ahead. So now when you present everybody, please concentrate what is happening, what are the possible mistakes you can do it, how to correct it, right? So you are going to come across almost more than 100 patients during this course. Every time I'm going to bring, or sometime even I might be the patient. So sometimes one of the student might be the patient, so whatever. But you are going to talk with different kind of people, and at the end, you can manage the people easily. You can talk to the people very easily. Okay, yes, go ahead.
அம்மா உங்களோட சொந்த இடம் எவிடமாம்மா?
மட்டக்களப்பு.
மட்டக்களப்பு. பக்கத்துல இருக்கிற ஆஸ்பத்திரி எவிடமாம்மா?
எந்த ஹாஸ்பிடல்?
உங்களுக்கு பக்கத்துல இருக்கிற ஆஸ்பத்திரி எவிடமாம்மா? மட்டக்களப்புலண்டா? மட்டக்களப்பு.
பக்கத்துல இருக்கிற கல்முனை.
Sir, very good. I'm impressing.
எவ்வளவு நேரத்துல அந்த
Listen,
பக்கத்து ஆஸ்பத்திரி போயிடும்?
stop. Listen. Now you are asking, what is your native place? Actually, she got admitted to DGH Mullatiu, right? So you are asking about the native place, and she's telling I am from Batikalo. So then you are asking, what is the nearest hospital to you? And she's answering, this is Kalmune. Kalmune hospital is nearest hospital. But currently she is living in Ottisutan. So from Ottisutan to Kalmune, it's going to be 300 kilometers. So it's your bus has gone. Tata. The examiner will see, we'll see tomorrow, next year. Bye. So this is how you are history taking, and actually when the Kavinda is asking Geval Kohide, she is telling Ottusutan, somewhere near to the Mullatiu. But when you are asking, she is telling Batikalo, and you are asking about the nearest hospital to the Kalmune from DGH Mullatiu. So now everybody might understand how the history taking, how horrible your history taking going to be. So this is the real challenge to me to correct everything. Okay, right? No worries. Go ahead. I will correct it slowly. Yes, go ahead.
இப்ப கூட வசிப்பிடமா விடுவோம்மா?
ஆமா.
ஒட்டு சுட்டார்.
ஓகே.
அம்மா நீங்க வசிக்கிற இடத்துல இருந்து பக்கத்துல இருக்கிற ஆஸ்பத்திரி எவ்வளவு தூரம் அம்மா?
ஹாஸ்பிடல் சொல்லப்போனா வஸ்கா சார்பூர் பாதி.
Right, fine. So now you can understand when you are asking in a way she can understand, right? So where are you living? She's telling Ottisutan. When you're asking, so how far the hospital is from your home, then she's telling it's 60 rupees for public bus. So then what you want to understand from this word?
It's a little faster.
No. So you have to be a rational person, man. She's telling, when you're asking about how far, she's telling 60 rupees from for reach the hospital from my house. So then what is her main transport?
Bus.
So then you can skip that. Now you know, right? So she's mainly coming, so she doesn't have three-wheel or vehicle at her home. So then you should not ask the question again. So, okay, Amma. So then if it is an emergency, so then you can tell with the patient like, then you are coming to the hospital by bus, right? So then patient is thinking, right, doctor know me something. He's understanding me something. This is how you are developing the rapport with the patient. So you are coming by bus, right? Okay, Amma, then if it is an emergency or night time, if you have any problem, how can you come? So then you are going to the patient's level. You are talking with that level. So then patient will tell, so in next to my house, there is a three-wheel, we can come. All right, so if it is a three-wheel, so then how expensive can you afford what your husband is doing? So now patient will think, this doctor is concerning myself. He is a real doctor. Got it? This is how you are developed. So at the beginning, when you are taking the introduction history, I am creating or I am making good rapport with the patient. This is how you have to communicate with the patient. No worries, right? Don't worry. So this is your first history. I will correct you. At the end, before the exam, you will talk like this with the patient. So you are going towards the patient and you are talking with the patient. So this is the same technique you are going to apply to the other subject as well. It's not asking the name, address. These are common to all the patient, not the obstetrics and other gynecology, everything. But I will teach you how to be a good doctor. So then the examiner also will impress when you are talking with the patient. So how you are, because that is how we are assessing. No, so I'm telling Nartana is good because she's talking very nicely with the patient. So then the first impression, what you are giving to the examiner, what you are giving to the patient. Got it? Right? Go ahead. This is how we have to correct the history taking So with the each, and so when we are studying the GDM, so while you are taking, so then I will teach you what are the things you need to ask. Then different patient might have different problems. So along with the problem, how we are going to take the history with the GDM alone. So that's why the first 14 class we will study how to, what are the things we need to ask for each and every cases. Then during the case discussion, we will discuss Niranjana, not the threatened miscarriage, not the GDM, not the epilepsy. We are going to talk to the Niranjana, and we are going to identify the problems, and we are going to gather information and identify problem list, organize your history, present to the examiner. Yeah, go ahead.
சரிம்மா, உங்களுக்கு ஏதாவது அவசரம் வேண்டாமா? பக்கத்துல இருக்கிற ஆஸ்பத்திரிக்கு போய் சேர எவ்வளவு நேரம் ஆகுமாம்மா?
Okay, we'll skip that one. Next question.
சரிம்மா, அம்மா உங்களோட ரத்த குரூப் என்னன்னு தெரியுமாம்மா உங்களுக்கு?
O plus.
Right.
Yeah. So then very good. So always when a patient with a pregnant mother presented with pervaginal bleeding, so always you have to ask about the blood group. So don't. So I will teach you what are the important things you need to ask in the introduction, right? So how to identify the presenting complaint, that is an art, right? So how to identify the presenting complaint. So I'm quite sure. So maybe few students came to my Viva class earlier, they might know how to identify the presenting complaints. So rest of the people, almost 90% of the people will not know how to identify the presenting complaint. I'm sure. I'll challenge you. You don't know how to identify the presenting complaint, right? So you don't know what is the real definition for the presenting complaint. So if you don't know what is presenting complaint, how are you going to take rest of the history? Got it? So you can't read those things in the book. You can't read, or you can't get these things in your YouTube channels. So that's what you need, some kind of person who is practicing. So because these are art, right? So you need to develop. Okay, go ahead.
அம்மா, நீங்கள் இந்த முறை ஹாஸ்பிட்டலுக்கு வந்த முக்கிய காரணம் எதம்மா?
நான் கர்ப்பமா இருந்தேன், அதால எனக்கு ஜெலக்கோல பீரியட் வரைனா வந்தேன்.
Right. So you were asking the main reason you came to the hospital, and she's telling I am pregnant and she had yellow color discharge with bleeding. That's why I came to the hospital. Right? Okay. What is the next question you want to ask?
Sir, last menstrual period, sir.
Man, she's complaining yellow color discharge with pervaginal bleeding. Then why are you jumping from here to there?
Which trimester, sir?
First you have to ask how long you are having this bleeding. Without knowing the duration, why are you jumping to the LRMP? Right? So just that is the important part. Okay, so how many days you are having? So I'm going along with the patient. So the history should be in a chronological order. Chronological. What is chronological order?
Time.
Chronological order?
Time based, sir.
Huh?
Time order.
Yeah, time order. Right? So how long? So like that. So history should be like that. So this is the worst ragging to this patient, right? Okay, right. So you have to ask the duration of the bleeding. How long you are having this bleeding? Okay, right. Go ahead.
எவ்வளவு நாளாமா இப்படி போகுது?
இப்பயே அப்படிதான் போயிட்டு வந்துருக்கு.
இப்ப மொத்தம் எவ்வளவு நாள் ஆகுதும்மா?
இல்ல.
இப்ப மொத்தம் எவ்வளவு நாளமா இப்படி போகுது?
இப்ப ஒரு 5 நாளா.
5 நாளா போகுது. இப்பயும் போகுதாம்மா?
Right. So now he's again and again proving how difficult to gather information from the patient. So this is not because of the language, this is because of the way of talking. So you are asking how many days? The patient couldn't understand what you are asking. Right? So the way you are asking should be understandable by the patient. Right? So I know you are asking the correct thing. So how long you are having bleeding? Still, are you still having bleeding? Those two questions you need to ask. Yeah, correct. But when you ask to the patient need to be understood. So if I'm telling something to you, if you can't understand, then what is the point of doing class? Will you come to my class? No. So when I'm telling, everybody need to understand what I'm telling you. Got it? So no worry. Right. Okay. Go ahead.
அம்மா இப்ப உங்களுக்கு மூச்செடுக்க கஷ்டமாவோ தலை சுத்துதான் இருக்காமா?
இல்ல இல்ல
அப்படி ஒண்ணும் இல்ல. சரிம்மா. உங்களுக்கு இப்ப கடைசியா ரத்த மாதவிடாய் இருந்தது எப்பம்மா? கர்ப்பமா முதல்ல?
10ஆம் மாசம் 15ஆம் தேதி.
Right. So okay, very good. So not bad. It's a good history, but what I want to show you is today I can't teach you how to take the history. So what are the information you need to gather? So how to analyze the symptom, how to identify the risk factors, how to identify the differential diagnosis, and how to exclude the differential diagnosis, how to exclude the complications on identification of complication, and how this complaint is, so this problem is affecting her quality of life. So those things, obviously I can't teach you because it takes time, but I just want to show you how difficult to talk with the patient. That's it, nothing else. How difficult to gather information from a patient. Even though you know something, even though you know these are the things I need to ask, but the way you are asking is not understand by patient. And second thing, uh, today I can't comment about your history, but you are missing a lot of information. This is not the way to ask question. This is not the order to ask question. Obviously the information you ask is correct and need to be asked, but there should be some organized manner. So you may have to ask, you have to give priority or some important to something, some factors, and something you can skip it. So that one you will get to know after discussing each and every cases. Got it? So this is just the introductory class. I just want to tell you how to approach the patient. So we will discuss those things in classes. So again I am telling, so please try to present the history, try to get practice. I'm not going to force you to present, right? So if somebody willing, you can present, but the good thing is you will get corrected by me. And other people, when somebody is presenting, just concentrate what are the mistake he's doing, how I am correcting, and how to solve those problems. So then I will teach you, I will show you the techniques, examination techniques, how to do the proper examination. Then you will get to know the proper practice once, as I told you, once this corona things lifted. So we will do the clinical session for the hands-on practice. Rest of the things, other than the hands-on practice, rest of the things you will get enough exposure with this course, because you are going to talk to the patient lively, right? So then you will get to know how to take the history. So your exam is going to be one of my class, not the separate event. It means you have to present, and every class should be like the exam. So then you won't get the adrenal surge and you won't get panic during the exam. So exam is going to be nothing. You just go like one of the gynae class or other class. Just go and do and come. That's it. So this time you are going to have a good chance, because probably as you are going to do the exam, so you are going to take into the internship with the repeat batch. There is a high chance to get 350 400 doctors to get into the internship. So if you do well, right, you can pass. So always you have to show to the examiner, I am a safe person, I am a safe house officer. You can believe me, I can work under you. You can go to anywhere, I will manage until you reach the hospital. That is the only information you need to give to the examiner. If somebody failed to answer, I will do middle cerebral artery peak systolic velocity, no one will fail you, right? So adjusting the insulin dose, starting the insulin dose, right? whose responsibility? Who is deciding that? Who is deciding that? Assessing the insulin dose. So those kind of management is decided by who? Yeah. Who? Who is deciding? It's consultant. So they will not ask, how are you? So the blood sugar series is like this, how you are going to adjust the insulin. That is not your responsibility. So if you do the part 2 exam, you are going to be the consultant, then you should know how to adjust the insulin. So then in that exam, they will ask, and you have to answer. If you are failing to answer, you will fail. If you are failing to answer, you will fail because you are the person going to make the decision. But in the undergraduate exam, in ERPM exam, you are not going to do the decision making. So if you fail to answer about the insulin dose adjustment and things, you will not fail. But if you fail to answer how to deliver the shoulder dystocia or how to manage the postpartum hemorrhage, then you will fail. Because delivering the shoulder dystocia, managing PPH, identify the ectopic, right? Missing the cord collapse, because you are the people going to be the primary managing people. So those things you need to know. So first of all, you need to know what are the things you must know, right? What are the things you can't do mistakes? Certain things you can't do mistakes. If you do mistakes, that is disaster. You will die. Next time on you. Right? So that is the exam. So it's exam, Viva exam is an art. You need to develop the art, get practice, do rehearsals, right? Do rehearsals and study. That's it. Then not only you will pass the exam, as I told you, you will be a good doctor. You will be a good doctor. Everyone will respect you. Right. Any question? So summary, we will start class in 16. So then after finishing stage 1 and stage 2, I will do the case discussion and emergency. At the same time, I will arrange the hands-on skill as well. Right. Any question? So what if don't know the Tamil and get a Tamil patient? It's applicable for the Tamil students if they get the Sinhala patient and don't know the Sinhala. So the answer is you have to study Tamil. The Tamil students have to study Sinhala. That is a simple answer. We will give. I'll give both the history, Tamil as well as Sinhala. But some station they might provide translators, but only problem, yeah, in mostly in Jaffna they are giving, and I think in Batti they are giving Tamil translators for Tamil patients, so you don't need to worry much. But the problem is you have only 5 minutes, right? You have only 5 minutes. So within that 5 minutes, so you need to ask some question for the translator, then translator will ask from the patient, then again translator will tell to you. So then it's taking double time. So then you can't complete the history. So better to try to know some important words or important things to take the history, right? So if you are struggling, then they might help. So don't depend on the other people to each and everything. That will not good for you as well. Okay, somebody asked about the class timing. The classes, it's going to be 3 classes per week. Thursday 5 to 9, Friday 12:30 to 4:30, Saturday 12:30 to 4:30. That is the timing of class. Any question? The long case 10 minutes or 20 minutes, it's 10 minutes. Within 7 minutes you need to take the history, do examination, and rest of the 3 minutes they will ask you to do the examination in front of them, or sometimes they might skip that and they ask to present the summary or history, and within 15 minutes your exam is over, done. So you are going to show your knowledge, your future is going to determine within that 15 minutes, right? So you spend a lot of money, a lot of time, a lot of effort, but it's going to determine on that 15 minutes. So you have to work hard to get practice to do it in that 15 minutes. That is the real secret. Yes, any question? At least for happiness, tell us why she has discharge. Which one? Which patient? What is the diagnosis? This patient, are you asking about this patient? Yeah, this patient got admitted with, yeah, she got admitted with threatened miscarriage. And now the baby is okay. Then tomorrow we are going to discharge with progesterone. That's it. Yeah, this is a threatened miscarriage. Okay. In fast, I'll do that. Yeah. Any question? Yeah, the patient is telling everybody is sleeping. No, right. So if you don't have questions, so we will wind up now. So uh, so we will meet coming Saturday, 12:30, right? Yeah, thank you for the Amma. Yes, they are thanking you.
Thank you.
Right. Okay.
Bye.
Okay, so then we will meet coming Saturday, 16. Right. Right. Thank you, Amma. Thank you.